We will ask Dr. Lauren to begin our panel presentation.
Well, thank you to everyone for being here and sticking through to the very end. I'm Dr. Lauren Goodman, and I will make sure that I can arrange just the green button, I presume. Beautiful. Very good. Well, I'm thrilled to be here. I know a number of people I've gotten to speak to over the past 6 weeks as I've started here at Jasmine as the new palliative care physician are generally familiar with what we do. But I think there are a lot of misconceptions out there, and I hope to help clarify some of those today. So originally, Jasmine was known as Cayman Hospice Care, and I think that's how people continue to think of us for sure. A few years ago, we transitioned and became Jasmine, and the intent of this was really to reflect our broader purpose. And so we are a nonprofit palliative and hospice care organization. And I think many people know generally what hospice is, but palliative is that piece that a lot of people, including people in healthcare, are not so sure about what that means. And so I hope over the next few minutes to give some clarification and to help share some opportunities for all of us to care for each other, for patients, for our community. So who is Jasmine? We have caregivers, we have nurses. Our caregivers are unfortunately, they're wonderful. There are 3 of them currently. So you can imagine we're able to come into people's homes and to provide some care, some assistance. That's not a full day worth of care, and it's not 24/7 care. We have me, the palliative care physician. We have our medical director, Dr. Ginny Hobday, who I think many of you have gotten to know over the years here. We have our wonderful director of operations and nursing, who I think may know every single person at this conference, Ms. Dion. And then we have wonderful volunteers. And our volunteers can help us with anything from administrative tasks to fundraising operations to coming into patients' homes and being companions to our patients. And we're so grateful and fortunate to have those volunteers. Finally, we have some grief coaches who can help with the process of bereavement after a loss. And what is Jasmine? So we provide pain and symptom management, which I think is sort of what's assumed. We provide support for patients and families as we're going through difficult times. We can help with decision making, kind of the thought process of, I have these options in my healthcare, but what's right for me personally? What matters most to me? I think that's a big piece. It's certainly in my previous work. I did a lot of work in the intensive care unit at a very, very large general and cancer hospital. And a lot of this is thinking about not just what are my options, but what do they mean? And what works best for me? And finally, I think the piece that everyone thinks of when they think of hospice and of Jasmine is end-of-life care, and that's certainly a piece of what we do. But I hope that I'm able to share with you that it's not everything that we do. So what else? Also the bereavement support piece for after a loss is a big piece of how we hope to be able to help the community. So when do we involve Jasmine? When do we involve palliative care? When do we involve hospice care? And palliative care, really, more and more studies are showing the importance of getting palliative involvement early on, as early as the moment of diagnosis of a serious illness. Can be at any time after that, but the sooner, the better. And that feeds into the cost savings piece, which I'll elaborate on. Hospice is the component of care. It's a piece of palliative care that we have involved, that we transition to when treating the disease is no longer possible or no longer desirable, when the burdens of those treatments are too much, and we're focusing on treating the whole person and not worrying about lab numbers, not worrying about imaging, not worrying about the disease. Where does it happen? So I think a lot of people are surprised to find that most of the care that we provide is in patients' homes. Between our caregivers and our nurses and me, most of our visits are in patients' homes. We do provide clinic visits as well. Currently, that's at HSA. We're hoping to finalize arrangements with Health City to have a clinic there as well. And I very much look forward to being able to see patients in both locations. And then also, we're able to come into the hospital to meet with patients and families, to meet with medical teams, to really help talk through what's happening, what do we know, what do we not know, and how do we make sense of it all? How do we do what's right for this patient at this time? Hospice, in some contrast, also mostly happens at home, and that's true here, it's true in the United States, it's true throughout the world. Most hospice care is provided in patients' homes. It can be provided in nursing homes. And then I'm hoping that a number of you have gotten to see our beautiful villa a little bit further south on West Bay Road. It's a custom-built facility. Currently, we have 4 patient rooms that are designed to help care for patients and their families. We can use it for helping to get severe symptoms under control if those symptoms are not able to be controlled well with medications at home. We use it for respite care. I don't know how many people here have provided care to a loved one in their home. Show of hands? I've done it. My experience was not particularly intense, but even so, those of you who've done it know it's not a lack of wanting to do it, but it can be really exhausting. And day in and day out, you give that love, you give that care, and eventually there are things that you need to do. You need rest, you need to take care of yourself. So we're able to bring patients in an arranged fashion and give those families some respite. Let them be the family and not the caregiver for a time. Typically that is a week at a time, sometimes as much as 2, but we're happy to be able to provide that service. And finally, I think the piece that people are most familiar with is if end-of-life symptoms are particularly severe and not able to be managed at home, or if the patient has been in the hospital and is having significant symptoms to where they can't be successfully cared for at home, we can bring them into the villa and help provide that comfort care at the end of life. So why do we do this? And I think historically, it's felt to a lot of people like, oh, well, treatment isn't working, or we're done with that, so you go over there and just you go away. And that's really not what it is. It's about helping people to live well despite serious illness. And yes, sometimes that is when they are at the end of life. But one story that I always carry with me, and this is representative of many, many patients. I met a patient who in 2012, early in the year, was diagnosed with pancreatic cancer. And I don't know that we have a lot of oncologists in the audience at the moment, but I think most people know that historically, pancreatic cancer, oh, that's bad. And at that time, 5-year survival was about 5%. So of all the patients diagnosed with pancreatic cancer, only 1 in 20 would still be living 5 years later. And so this patient was really despondent. She had one grandchild who was very, very young. Will my grandchild remember me? Will anyone remember me? How bad is this going to be? How soon am I going to leave my family and my loved ones? With good quality palliative care, she was able to tolerate 4 or 5 years of treatment. She got to no evidence of disease, and she lived for 11 years after diagnosis with metastatic pancreatic cancer. She lived well. She continued working, she continued traveling, continued volunteering. She lived her life. She got to meet 2 additional grandchildren who remember her well. And in fact, she died of a completely separate process. But palliative care is about helping people to live well. It's about helping people tolerate these treatments that we know can be incredibly difficult, incredibly toxic. and helping them to live each day as best they can, hoping for more good days. How do we do it? So every time I say this, it brings a tear to my eye. We are able, and I am so thankful, and we are all so thankful to be able to provide this care to the entire country free of charge. And that is thanks to all of you, and thanks to this incredible country. You can probably tell from my accent that I'm fairly new here, about two months on island, and just loving it. And just every time we tell someone there's no cost for our care outside of the medications that your insurance will cover, it warms my heart, it brings tears to my eyes to be able to do this without burdening our patients and our families any more than they already are is just incredible. So a little more about what is palliative care. Obviously, we've talked about it's managing pain and symptoms. It's communication. In palliative care and hospice, we get tremendous amounts of education and training and ongoing training in communicating with people who are going through incredibly difficult times, thinking about their condition now, thinking about the future, thinking about uncertainty. Anyone who's dealt with a serious health condition for themselves, for their loved ones, knows the uncertainty is incredible. It's thinking ahead to those bad situations. It's making sure that we improve quality of life no matter what's happening with the disease. And in fact, there's a rather well-known study that's about 10 years old now, the Jennifer Temmel study, that shows, and several others that have come out since, that shows there are some conditions where if you get palliative care involved early in the course, you will actually live longer. In particular, this initial study, the Jennifer Temmel study, showed about 3 months longer life in patients with lung cancer, and that was despite less use of aggressive measures at end of life. They lived longer, lived with care that was more in keeping with their values and goals. So what is hospice? Super briefly, I get very excited talking about all of this, so I think I'm taking more than my fair share of time, so I will try to pick up the pace. Again, hospice is a phase of care that we use when treating the disease isn't possible, or when it's no longer wanted, when the burdens are too much. I get too sick from my chemotherapy. It's not helping my disease as much as it's causing my quality of life to suffer. And sometimes, particularly in the hospital, particularly in critical care, I'll hear people referring to withdrawing care. We never withdraw care. We may withdraw some of the life-sustaining therapies. We may withdraw things that are treating disease. We never stop caring for you, ever. And again, the goal of hospice is to help people live well, even if we know a disease is killing them. We support the patient, family, and caregivers. In general, we try to keep people comfortable at home, and we try to stop things that are burdensome and not helping. I've covered these pretty effectively. And again, palliative care does not mean not trying to treat the disease. That's, I think, the most important thing. Very quickly, there's a well-known myth that's been going on for decades and decades that if you enter hospice today, you're going to be dead in a few days. It does happen sometimes if people are referred when they're dying. People who are referred earlier on in their disease process can live for months. I've cared for patients who've lived for 4 years in hospice. They were still appropriate, but they somehow got that miracle of good quality of life and continuing on. You also are not required to stay in hospice until death. Some people do improve with less aggressive therapies, in particularly people with lung diseases I've seen get to be too functional for at least the US criteria for hospice. All right, and then very briefly, how does palliative care save money? If we control symptoms better, we don't interrupt our treatments as much. If you're not too nauseated to take your next round of chemo, you're gonna be able to go on and get it. We don't lose work days for the patient, for the family. We don't go to the ER as much. That's a huge burden, both cost-wise, resource utilization-wise, and fewer admissions to the hospital for uncontrolled symptoms. You can imagine that it's very difficult to quantify, but really talking about what matters most and how do we make the best use of your time? How do we take care of you in the way that's right for you? Often that means avoiding things like intensive care, like a breathing tube, like a ventilator, like dialysis. If we don't talk about it, sometimes those things happen in an emergency. And then we're stuck with, okay, we're on this, we know the disease is still really severe. What do we do? Very good. And the earlier we refer, the more we save. And with that, I will provide our website, our email information. We take referrals from healthcare workers, from families. Please feel free to contact us with any questions. If there's a situation where you think we can help, we're happy to talk it through. And thank you so much.
Good morning, ladies and gentlemen. I think it is still just good morning. I'm Andrew Vincent. I'm the chair of the Cayman Heart Foundation. It's my privilege over the coming years to steer the foundation in terms of looking at what its role should be in our ecosystem. It wouldn't be where it is today without the absolutely inspirational and tireless work of Susie Soto, who has brought it to where it is and obviously touched so many lives. So our theme going forward is Save 100 Lives, and I would say it's because together we can, that's the first thing, but collectively we can't afford not to. Cardiovascular diseases are still, in actual fact, that collection of diseases that represents the #1 leading cause of death throughout the planet in all major Western nations, and of course, including the Cayman Islands. And part of the reason why it holds that top slot is, of course, it is a collection of diseases. It's not just a single disease. Everything from coronary artery disease, which we have high familiarity with, but also sometimes we forget that things like stroke, of course, is equally part of that problem. And it's structural problems, it's genetic problems, problems that sometimes are difficult to identify at birth but exist at birth. It's a very, very big collection of things. So it's a hugely intractable problem. And when you start to compare it to some of the other areas of disease, what you realize is it's an order and a magnitude greater in terms of its impact on people's lives. So what I want to do is I want to take you through a life, and in actual fact, this a little bit of a story about my life. But I think actually it's a life that's representative of many lives. So we start out young, fit, healthy, enthusiastic. We're focused on careers, but we also have the ability to gradually erode our health through our lifestyle. And if when you look at the image on for you, the left of the slide, you can see this nice progression through life. And eventually what happens, of course, is your lifestyle catches up with you. And cardiovascular disease is obviously very, very influenced by the lifestyle that we lead and some of the decisions that we take. And eventually, having caught up with you, and by the way, I think probably everybody who has an unhealthy lifestyle is always going to do something about it next year. Or at Christmas. We eat too much at Christmas, then we set ourselves a New Year's resolution. And I would think that there's a great many people in this room, myself included, that every year our New Year's resolution is the same. And that's probably telling us something already. But eventually it catches up. And it caught up with me a few years ago when I had a cardiovascular event on, of all days, Valentine's Day. Now, I am privileged to live in a jurisdiction that actually has incredibly good emergency cardiovascular care. And so, I'm here to be able to talk about it because of the access that I had to that emergency care. And when we look at our hospital facilities, the access we have to cath labs, to imaging, to treatments, assuming that they are affordable to us, that actually we've got some of the best care, I think, in the world. But then when we look at where the money is spent across our lives in relation to our health, our spend on primary prevention and early identification is tiny compared to what happens if you allow yourself to reach that point February the 14th, where you have a cardiovascular event. And that's been a theme of this conference. And actually, you know, for my 8 years on island, it's been a theme of my time on island in healthcare. Now, that's really reinforced when you look at something like the standard health insurance contract that we have, the basic level of cover that people have access to. And if you're thinking I've forgotten to put a couple of bars on here, it's actually because they're so small in relation to the hospital and inpatient and outpatient care, that care that I benefited from when I had my cardiovascular event. And if you look at those, you've got doctor's office fees, labs and drugs. So already here, this is someone who's presented to a doctor with a problem and now needs that sorting, and that's at $400. And the wellness, well child and dental coverage is at $200. And so when I put up cents throughout my life, from a prevention point of view, primary prevention point of view, and then dollars, lots of dollars, a sack of dollars at the intervention level, what you can see is that we've got a very, very unbalanced system. Now, this is one of the first areas I think where charity really has a big role to play. Because typically, of course, intervention and technology follows where the money is. And so the money here is very firmly implanted in hospitals, for technology and intervention and rescue and all of those things. It's not implanted in your ability to be managed with a condition through your doctor's surgery, or even to have that condition identified very early on. So if something like a charity is going to intervene and save lives, we have to ask, are these lives that can be saved? And if so, where in our ecosystem is our charity best applied? So in terms of can the lives be saved, this is looking at the main causes or risk factors for cardiovascular disease. Obesity, hypertension, diabetes, smoking, we're very familiar with these. Lifestyle-related issues, a sedentary lifestyle, unhealthy diet, greater stress. Of course, limited access to healthcare is one of those. And I want to add one to this list, which is this is a behavioral challenge as much as it is a lifestyle challenge. And I think sometimes we think that the lifestyle challenge is a behavioral challenge. But when I had my cardiovascular event on Valentine's Day, it was a behavioral challenge getting me to even take that seriously at that point, because I'd got a reservation for the gazebo at Grand Old House, and I had an entirely different evening planned than the one that I ended up with. That was a behavioral challenge. But when you look at these, obviously excluding the Grand Old House episode, these are all modifiable, and therefore we can intervene and save lives. And so the Save 100 Lives by the Cayman Heart Foundation first starts with understanding the risk factors, the signs, and the symptoms. And we're going to do a little bit of a test on that in a moment. So we like to think, of course, that because cardiovascular disease is so ubiquitous that we all understand it and the risk factors and the signs. But that's not true, and I think charities have a big role to play in that health promotion component. We want to focus on weight. You've heard it, whether it comes to dementia, it comes to, this morning, gynecological health. Almost every one of our diseases is impacted, certainly our major communicable diseases, non-communicable diseases, I should say, is impacted by weight. And so that's going to be a key focus for us going forward. And it was a focus in the past as well. We're going to revitalize our efforts in that area. We spend a huge amount of time at work. And it's said, of course, that sitting is the new smoking. And therefore, employers have a role to play in overall health, but particularly in cardiovascular health. And so we'll have a program this coming year around heart-healthy employers, where we really want employers to start learning about and embracing how they can create workplaces that ultimately lead to much, much greater health. And then I think the final component of this, which is so important, which has obviously been enduring for the Cayman Heart Foundation, is the role we play in screening and knowing your numbers. And that's including the education around even which numbers to know. And so every morning I go for a walk, and if someone asks me later on in the day, how many steps did you do today? I whip out my iPhone and it tells me I did 6,738. And then if someone said to me, what's your blood pressure? I'm like, oh, maybe I ought to go and get that checked. And so we've got a lot of work to do to encourage us to engage in the types of checks that we need to do to be able to identify our issues early. And these are very, very practical things. They do require funding, and sometimes when I talked about, obviously, where the money goes, if you relied on the health system to be able to provide all of these things. We already know, with an insurance-based system, the money sits in largely the wrong places. We've got materials to produce. We've got education programs to run. We're going to have guides as to, how to effectively lose weight. I'm going to talk about it in a realistic sense because, we've all been given guidance on how to lose weight. I'm still overweight. It's not that we don't know what to do. It's a much bigger problem than that. So we've got to work on those things. We can run healthcare screening programs inside of employers, nutritional wellness days, direct checks on people's heart health as part of those interventions. And then, of course, there's the public screening programs that we will run as well. Now, of course, the work of something like the Cayman Heart Foundation is not just about those things. That's the Saving 100 Lives campaign. But there's also things like making sure that we've got the right life-saving equipment in the right places, so AEDs. And we've had incidents recently where people have had access to an AED, but they haven't known what to do with it. So, of course, there's the educational component around the use of AEDs. I feel that we also have a role to play in things like advocacy. So my son went to St. Ignatius School, one of 3 schools in incredibly close proximity to each other. What's the next nearest thing in close proximity? Burger King. We've got to start thinking at a society level about how we structure that society so that we start off our youngest generations on a journey of health, not a journey towards ill health. The other thing, I live midway up 7 Mile, but I live on the canal side of Esterly Tibbets. I actually take my life into my hands crossing that road. But I can't walk up and down the road because there isn't the pavement structure there to be able to get to a proper crossing. We have to make it easier for people to walk. Otherwise, walking's not safe. Cycling, I don't even want to start on cycling. And then there's the support that something like the Cayman Heart Foundation can provide to people that are struggling with affordability. And sometimes it's not the access to care, it's the fact that they may end up in somewhere like Miami and they want their family with them at some of the most stressful times in their lives. And actually that can be an incredible strain on those families. And of course we do provide support for families in need around that. So I said that I wanted to do a little bit of a test, and I've said that obviously a big part of our role is in education and making sure people are aware. So the test I want to do is that we all know that shoulder pain, arm pain is a symptom potentially of a cardiovascular event. What I want you to do is I want you to raise the arm that you think is the one where you get this symptom being expressed. So, what I can see is a huge number of left arms, and I'm very pleased to see 1 or 2 people with both their arms up. So for me, one of the reasons I did not take my cardiovascular event seriously was it started on the wrong side. Well, that's obviously not heart disease, is it? And in fact, I'm a tennis player. I'm a right-handed tennis player. So I was pretty sure that actually I had nothing more than an injury from being over-vigorous in my competitiveness. It wasn't until I had my cardiovascular event that I realized. And then, of course, you look it up and you go, oh, no, actually it can be there as well. If you left here today and a tennis player that you know started going, oh, would you say to them, that could actually be cardiovascular disease? Well, do so after today, and we will have already started on a journey of education and hopefully saving lives. So thank you for your time. I think we've got a huge amount to do. I think that the role of charities is to fill in some of those gaps. I think we work at a different level. We work at a behavioral level, not just an intervention level. But I think that what we can do together as an ecosystem, with all of its weaknesses and all of its strengths, is together we can definitely make a difference. Thank you.
Thank you, Andrew. I am Beverly Edgington, the Chief Administrator of the Breast Cancer Foundation. And for those of you who don't know where that's based, it's at Grand Harbour. I live in South Sound, so I equally take my life in my hands at least twice a day trying to get across the Hurleys roundabout. So I may need to call upon the Cayman Heart Foundation. I feel I do at 7:45 most mornings. So, as I say, I'm the Chief Administrator of the Breast Cancer Foundation, and we're incredibly proud to say we're actually celebrating our 15th anniversary. We're 15 years and 2 weeks old today. Thank you. And when we first were established, we were actually established as a fundraising entity, and that was it. We raised some money to give back to other charities in the community, and in particular to the Lions Club of Tropical Gardens, who have adopted October for themselves, and also to the Cancer Society. And as a foundation, what we're incredibly proud of is the fact that we do work very closely with other non-for-profits. And I think that that is something that a lot of criticism gets aimed at all of us, but I can look along this panel to know that we actually work with all of them, and we work together, and I really would like the public health community as a whole to know that. We're not standalone, and the Minister said last night that we're not in competition with each other. Actually, what's really important to all of us is that we are working together. We send patients to Jasmine. We have patients who, as a result of their chemotherapy, may have heart issues, and also for us, mental health is incredibly important, and what we are doing is we're taking the children whose mothers and fathers, because men get breast cancer too, and we will send them to Alex Panton or something equivalent, because that's not our area of expertise. So we will look to these other entities to ask them to help us. So the cost of healthcare, especially for breast cancer, is really rising at an alarming rate. What's really interesting for those of you who don't know is breast cancer is the most expensive cancer. You can be on exactly the same chemotherapy for prostate cancer and breast cancer, and it's 3 times the cost for breast cancer. I think they see women and they just think this is what we're going to do. So these are just some statistics from year to date for the Breast Cancer Foundation, and I'm really sad to say that these are already out of date from when I sent these to Laurie. But the statistics are that we are receiving between 1 and 8 new cases a month. This week we had 3 new cases on Monday and Tuesday. The active cases that we're looking after is somewhere between 53 and 65 a month. And at the moment we're giving out in the region of 260 mammograms and 140 ultrasounds so far this year. What I do want you to know is everything that I mentioned to you, there is no cost to the public for any of the work that we do. We are totally and utterly funded. Thank you. So there is no cost, but last year we gave out 260 mammograms. This year we've already given out 260 mammograms. The cost of healthcare has gone through the roof, and the cost of living has gone through the roof, through the sky, through the clouds, and is on its way to the moon. And so what we're finding is that women, and I'm going to mainly refer to women here, although I would like you to know that 2% of breast cancer is now in males, but I'm going to mainly refer to women, that when you go and it's time for your annual mammogram and your healthcare, if you've got insurance, that's the first thing, and if you've got just the basic plan and you've got $400 in your wellness program, that's 1 trip to the doctors and maybe some antibiotics. If you've got an earache, it could be a little bit more. The average cost of a mammogram is $500. So if you're not covered, you're going to sit there and say, you know what, I'll leave it till next year, it's nothing. But it could be something. And so what we're trying to let everybody in this room know, so that they can go on to tell everybody else, till at the point that there is nobody in the Cayman Islands that doesn't know this, that if you need a mammogram, you come to the Breast Cancer Foundation and we will provide you with a free mammogram. End of. If you then need an ultrasound, or if you're under the age of 40, we will also provide you with that. Okay? So there is no reason. I meet women all the time, and they'll say to me, well, I had a mammogram last year, and so I'll have my pap smeared this year, but I can't afford to do both. Well, you can, because we will pay for it. I mean, maybe I shouldn't be saying in public that we will pay for it, but we will pay for it. You can, and all that we require from you is a referral from your general practitioner. And the reason we require a referral is because the results have to go back to somebody who is medically trained to then give you the results. You can see our active use, active cases and vouchers. So you'll notice that what happens, I think, so in March, we gave out more vouchers. So then you see in April and May, the knock-on effect is that we have a higher number of new cases that are coming to us. Something that I really need you to understand, though, is this is no longer an old lady's disease. It used to be an old lady's disease. It isn't anymore. First of all, I've already said 2% is now male. 2 years ago, it was 1%, so that has doubled. And as a foundation, we personally have helped and supported 3 gentlemen, all Caymanian, that we've helped. Okay, so we go on, of the last 20 cases that have come to us, 18 of those are age 40 and under, and half of those were 35 with young children. That means that what we are looking at is actually the dynamics and how we're supporting is changing. We've actually got someone in their early 20s that has been diagnosed in the last couple of weeks. The youngest person we've ever helped was 19, the eldest person was 91. This is not a disease that discriminates. It doesn't know how old you are. It doesn't know the color of your skin. It doesn't know whether you're a man or a woman, and it doesn't know what religion you practice, if you practice any. It's non-discriminatory. And so therefore, we want to be there to serve and help everyone. So what are some of the costs of breast cancer? Well, obviously, we've got the screening mammogram, but there is also the diagnostic mammogram and ultrasound, which is a lot more expensive. Then, should you be diagnosed, you're going to go on to an MRI or a PET scan. Unbelievable amounts of blood work. Surgeries will include lumpectomies, mastectomies, lymph node removal, and then maybe onto breast reconstruction. There's radiation to kill the cancer cells. There's chemotherapy drugs. We had a request from somebody whose insurance has run out. Basic insurance, $120,000 a year. She was only diagnosed in March. Her insurance is run out. It's October. She has 3 rounds of chemotherapy left. Once every 8 days. Each round is $14,000 US. She has no insurance. Okay, so that type of person, this is where the NPOs work together, will go to the Cancer Society. The Cancer Society will help out on a financial basis, but they give you $15,000 a year. That's gone in 1 round, so then they will be coming to us, and then unfortunately with this particular person, we will then be reaching out to Jasmine to be helping. But that's how these, as NPOs, we work together. And then obviously you go on to targeted therapies, immunotherapy. You may be on something like tamoxifen for 5 years. You also need to have a visit to see your oncologist, first every 3 months, then go on to 6 months, then annually for 5 years. You're going to continue to need your mammograms, and in particular, you're going to be needing a mammogram on your remaining breast. And unfortunately, in a lot of cases, you then may need to have a mastectomy on both sides. Who in the room knows that pelvic examinations are also important once you've had breast cancer? Well, the first time I saw a bill through for a pelvic examination, I was like, that's the wrong end. We deal with this end. But actually, uterine cancer can come out of the drugs that you're taking. Bone density and medications to reduce your risk. And then we've got indirect expensive physical therapy for pain, tightness, swelling in your arms, lymphedema. We've got, I don't know if she's in the room because I haven't got my glasses on her, but we've got a young Caymanian called Summer Phillips who has just graduated as a physiotherapist. And in November, we're very proud as a foundation to say that she's going off island to do some manual lymph drainage and lymphatic drainage courses that we as a foundation pay for. So we actually have a training budget that people don't realize that we have. I do believe at HSA there are 9 physiotherapists that we have personally paid for their training, and they're also in the private sector. Mental health, I think we've already touched on that. We have support groups and we have counsellors that we work with. We don't just work with the women who've been diagnosed, but we also work with their partners and their husbands. We also work with their family. We pay for all of that treatment. Acupuncture, believe it or not, really helps with nausea and fatigue, and it's probably not covered on your insurance. You come to us as long as you're signed up. Wigs, hair loss. We have over 250 wigs in our wig room, as we call it, because we're not clever enough to think of another name. And actually, Dr. Lundy Richards has actually asked us to be able to put a satellite wig room into HSA so that we're there to be able to help the ladies. But not only do you lose the hair on your head, but you lose your eyebrows, so we pay for microblading. We send you to get your eyelashes done. Who in this room knows that when you're having your chemotherapy, your nails may turn black? And so we will send you for that. We will send you for massage. This is all about living with, not dying from. This is all about living beyond the scar. And we are incredibly, incredibly proud to announce that last week we actually won the Community Initiative of the Year for our Beyond the Scar. And Miss Lizette was there. So these figures that are up on the screen, these are actually based in the States, so you can imagine it's a lot more here. But you're looking at somewhere between $48,000 and $70,000 if your breast cancer is caught early, up to $182,000, and that figure is so low. I know that figure is incredibly low. So what we do is we're out there, we're doing the same as Andrew is saying. It's all about educating, it's all about advocating. Something that I want you all to understand is Cayman Islands does not have the #1 amount of cases of breast cancer in the world. That is a fallacy and a myth that is out there. We're actually ranked at about 51, which globally we're bang smack in the middle. Barbados ranked at 79. They are way worse than I, and the minister and I were actually talking about this last night. And why is Barbados figures? They don't have what we have here. We're incredibly proud to say that over a 10-year period, the case load here in the Cayman Islands, currently approximately 70% of breast cancer is now caught at stage 0 or stage 1. 10 years ago, 70% was not caught till stage 4, and that is as a direct result of the wellness program and screening that we are doing in conjunction with you guys. We can't do this without collaboration, and we can't do it without partnership. We are incredibly proud of the fact that we work with all of the hospitals on island, all of the clinics, and they work with us to be able to, I'm saying to you that a mammogram is $500. We don't pay $500 for a mammogram, but that's what it would cost you. But we can't do that without HSA, without Health City, and without Doctors Hospital working with us. So as a non-for-profit, we understand that we need to be able to provide this holistic support. We can't do it without everybody, and we do play a very critical role in mitigating the rising costs of healthcare. We do it through fundraising. We do it through education, we do it through partnerships and direct patient support. It is a community effort, and this continued collaboration between both the healthcare providers, the sponsors, and the non-profits ensures that the patients get the care they need without the burden of overwhelming costs. And at the end of the day, we are going to make a difference in the fight against breast cancer, because if everybody looks to their left, please, indulge me, and now look to your right, 1 in 3 of you will be affected by breast cancer.
My name is Emily Kelly. I'm the Executive Director at the Alex Panton Foundation. I'm really grateful to be here today to connect with you all and the other NPOs. It seems that there's a really prominent theme of education and advocacy that stretches across all of our organizations. So a little bit about the Alex Panton Foundation. We are a nonprofit organization that focuses on, I don't have the clicker. Oh, fancy, here I go. I've arrived, thank you. The Alex Panton Foundation is a nonprofit organization focused on destigmatizing mental illness for children and young adults in the Cayman Islands. So really focusing on advocacy, awareness, and support for teens, kids, and young adults who struggle with particularly depression and anxiety. We know that there are a lot of members of our community struggling with that. And we address those by offering a number of programs, initiatives. We do community outreach and connect with schools, with corporations, in general public spaces to offer education about a variety of mental health topics, helpful coping tools, how to navigate those, and where exactly you can seek out support locally. One of the programs that I'm here to talk to you today about is the Financial Assistance Program. This is truly our largest output for the Alex Panton Foundation, and we partner with service providers. All of them are listed here, and we're so grateful for their partnership and their ongoing support to provide this very needed service to Cayman. How we go about it is it's for anyone under the age of 30, and people can apply directly through the service provider. So if a young person is in need of mental health treatment, mental health care, they would go directly to the service provider, let them know, I'm interested in applying to the Alex Panton Foundation Financial Assistance Program, and then they would then do their intake session. And so the service provider would liaise directly with us and provide a proposal of a treatment plan, what the timeline for that would look like, as well as the associated costs. And then our APF Financial Assistance Committee would review and get back. And we do not turn anyone away if they provide all the information necessary to reveal that they are in financial need, that they have exhausted their insurance and sought out government assistance. It really is just a matter of how much support we have capacity to provide, because of course we are an NPO. All of our funds come from really generous donations and fundraising efforts. I want to talk a little bit through the growing need on access to mental health services. So if any of you were here yesterday and heard Dr. Chantal Basson's speech, it was incredibly powerful, and she mentioned ACEs in the Cayman Islands. So we partner with the National Drug Council to collect mental health data biannually, and ACEs are adverse childhood events, and so really it's a strong indicator of trauma that our young people are experiencing. You can see with the statistics, 23% of young people that completed this survey had experienced 4 or more adverse childhood events. And you think about the implications that that has on their quality of life, their mental health, and being at such a young age, struggling to find the tools and the skills to cope with all of that trauma. And so it's really important to recognize, alongside the trauma, the generational trauma that our young people are bearing as well, we also are all experiencing collective trauma since the COVID-19 pandemic. I know Dr. Basson yesterday in her speech mentioned that we all went into our rooms and we never quite came out. And I think that rings so true and is a really, really important indicator that our community needs mental health services. We need access to that, and people really should not be in a position where they're having to choose between financial stability and their mental health. And so that's why this program is vital to the community, where, I'm getting ahead of myself here, where people are really struggling with coping with everything that they're bearing. And so these are also statistics of when young people experience trauma, when they are struggling with their mental health, and they do not have access to treatment, or they do not have healthy coping skills, they will turn to self-harming behaviors. Most prominent in Cayman is drug abuse and alcohol use, and we also see that if they really are having a difficult time coping with the unbearable pain, that they may turn to physical self-harming behaviors and even experience suicidal thoughts and feelings. And these are some of the statistics that also came out of that 2022 data collection through partnership with the National Drug Council. And it's pretty alarming to see. It was 2.7 of boys reported that they had attempted suicide in the 2020 survey. 14.4% of girls had reported that they had attempted suicide in the 2020 survey. That's a really hard thing to hear, especially considering how small our community is, and you think about the number of kids that those percentages represent that are feeling such unbearable pain that they have considered suicide and they have attempted suicide. And that is a direct reflection of access to mental health treatment, access to mental health care, and safe spaces to seek help, and understanding what help is available to them. I want to highlight a little bit as well the tangible challenges of accessing mental health services. And so generally, with offering mental health care, it takes approximately 8 to 16 sessions to really see progress, and that is accounting for more common mental health difficulties like depression and anxiety. That is not at all an indicator of in-depth trauma treatments. And as I mentioned earlier, our youth have experienced a lot of trauma. Our community has experienced a lot of collective trauma. And so at the bare minimum, the average to see progress is 8 to 16 sessions. It's approximately 200 to 250 per session, for one session. There are a lot of young people that end up having to do 2-3 sessions a week to support the crisis that they're in. So this is not even mapping out over a few weeks. And most insurance companies, their mental health cap is about $1,500. That is barely covering the bare minimum treatment that young people need for the bare minimum mental health services. It's not accounting at all for extensive trauma treatment. And this is also really difficult figures to see right in front of you. We know as we go about our day-to-day life that, yeah, therapy is expensive, but when you think about the practicality of what ongoing treatment looks like and how intensive it needs to be for young people who are especially struggling, for young people who have experienced a lot of trauma, and the barriers that exist on accessing proper treatment for that, it's really important to see it as plainly as possible. This is an outline of some of the numbers of how this financial assistance program has supported our community. So to date, we have awarded $394,207. So that's been awarded to young people under the age of 30 who are seeking mental health treatments. And of that number, we have actually paid out for services $235,000 and $409,000. That is an incredible accomplishment that we're so grateful for, and we know, as it's been mentioned so many other times today, it is not something that APF could do alone. We rely heavily on the community's generous donations, on fundraising efforts to be able to provide this service that fills a critical gap in our community. A total of 117 young people have received financial assistance to date from us. We're very, very proud of that number. And then as of today, we also have currently 84 people enrolled in this program that are receiving ongoing treatment through our services. I have at the bottom there that our youngest recipient is 6 years old. I think it's really important that we highlight that, because I know when we talk about mental health, a very common point of discussion is what do our young people have to be stressed about? What do our young people have to be struggling with? And the reality of our modern society is there is a lot. Things have changed drastically from just the generation before, and they are coping with a lot. They are exposed to so much more. As the data has shown, they have experienced so much more trauma. And it's really, really important to highlight how we serve under 30 years old and go to as young as 6 years old. Because if they need that resource, we want to make sure, especially early on, that they have access to that and have a better chance for a better outcome as they move forward and grow throughout their life. Also highlighting again that we do not turn anyone away, If they have met all of the criteria and they have affirmed that they've exhausted their insurance options and government assistance. Something I'd also like to highlight here as well is NAU is overloaded. I mean, you talk about the demand of the community right now, resources across the board are stretched thin, and so they have a really long wait list. And so while people go through NAU and they do their very best to go through all the proper channels, people could be waiting for months on that wait list because resources are stretched. Like we really are experiencing a lot of mental health difficulties in Cayman. And something else I'll add to that is that NAU is for Caymanians. And as we know, we have a really large expat population in Cayman. People that are a part of our community that we know, that we love, that are contributing to society, that are struggling and also battling with the cost of living and need access to mental health resources. Their children need access to mental health resources. And so APF is a resource that they can turn to. So our financial assistance program is available, of course, to Caymanians, also work permit holders, status holders, permanent residents holders, and it's really important for us to get that messaging across that anyone that resides in Cayman and is contributing to this society and struggling with their mental health, this is a resource that is available to you. Okay. So while we do everything we can through the financial assistance program to fill those gaps to accessing mental health services, we will absolutely continue to do everything else through our other programs. Our core values are awareness, advocacy, and support, and so many of our programs embody those practices. We have online support groups that we ensure are accessible both for teens and young adults. We have virtual lunch and learns where we're spreading awareness throughout the community. We offer emotional literacy programs in all government primary schools and a few private schools. And that is really building social and emotional wellness skills from an early age to give them the tools to cope well and to have the knowledge on how to navigate adversity when it comes, because inevitably we know that it does come, and we want to just make sure our youth are equipped with that. From an advocacy perspective, our youth ambassadors are really, really important to us, that we empower young people to peer educate, peer advocate, peer support. And so through that program, we offer educational workshops to our youth ambassadors so that they go out into the community, they go into their schools, and for our young adults, into their workspaces, better equipped and more knowledgeable about a variety of mental health topics. And we offer other skills workshops that help them offer support in compassionate ways, and I'll refer back to Dr. Bassan again, our clinical and education chairperson, who talks so much about how valuable compassion and connection is, and how those little interactions every day can be so therapeutic and can keep us afloat when we are really struggling with our mental health. So being able to do that through our youth ambassadors is a really, really important part of our work. And our legal and policy committee, we know that the ministry is working diligently to be more mindful of mental health and how we can formulate legislation to be more conscious of that. And so our legal and policy committee is really, really eager to contribute to that wherever possible, because we're seeing a lot of this through not only our financial assistance program, but as APF continues to grow and evolve, we are really, really grateful to have become a safe space for so many people to share their mental health difficulties and where they really need support. And with all of that feedback, with all of that information, like, we're grateful to be able to pass that along to the people that can really make change. And I just want to emphasize time and time again, mental health is equally as important as physical health. It needs to be prioritized on the same level. And that needs to be reflected through insurance coverage as well. A $1,500 cap on mental health services is a disservice to our community. And I thank you all so much for your time and for your ongoing support of APF.
Thank you very much, panelists. And now we have just a couple of minutes so we can take a few questions. Just raise your hand if you have a question. There's one here and then one over on the side.
Thank you all. Thank you all very much for those fantastic presentations. I would also say about mental health, last time I looked, the brain is in your body. So it is your physical health. It's not physical health versus mental health. Mental health is physical health. And I always say to people, diabetes is a disease, and so is whatever other mental disease. So we don't separate them from each other because they are part and parcel of the same thing. And I think that's a message we need to get across, is that they're not separate. The other thing I was going to say to Beverly is, just to mention that the Breast Cancer Foundation has done a brilliant job with providing wigs, but also with the cold capping, so that, provided machines to all the hospitals, actually, I think, if I'm right, at least 2 of them anyway, to do cold capping so that people actually don't lose their hair. And that involves a lot of time, volunteer, work, and educating people about what cold capping involves, because it's not that easy, but it can save hair, and for people who are working and for people, who it matters to, it's a really great thing, and we have it available on the island, not just for breast cancer.
Not just for breast cancer. So the Breast Cancer Foundation have actually funded cold capping machines in all of the hospitals, but we don't have them available. We're quite particular that they're not available just for breast cancer. So they're available for all cancer patients, and we just literally 2 weeks ago purchased a new machine that went into Health City via an anonymous donor, and HSA, Nurse Mitzi, has just submitted a request to me for a second machine to go into HSA, and there is also a machine at Doctors Hospital, and we do have a request for Faith Hospital in the BRAC as well. So, yeah, so that is something that we do. And those machines are not cheap.
And just a comment to the primary care providers on the mammogram vouchers, that obviously, please use people's insurance first if they have good plans, because people have come in and said, I want to save it for something else. And if they have a good plan, that's fine. If they've exhausted their plan or they don't have any wellness, then they can apply to the Breast Cancer Foundation. But we do want the insurance companies to be responsible and pay for wellness.
We'll pay enough money to our insurance company to start with. Please use your wellness portion more. If your wellness portion is exhausted, then come to us. But we can't do this without the general practitioners out there referring people to us. So that's what we're there for.
Okay, one more question, and then we will wrap up this segment.
I have a comment more so than a question. Thank you so much, panelists, for your presentation. And it's good to know that there are organizations that are there that is helping, especially Alex Panton Foundation, because I'm biased, because young people, they're my jazz. But I want to make mention the presentation you made about accessing mental health services. The unfortunate truth is, not only is that an issue, but there are, and I'm speaking from experience, right? So the lack of support for organizations that are on the protective factor side of things, not just necessarily dealing with risk factors, because it's both that we need to deal with, making sure that our young people have access to programs and are able to participate is very important. What do you suggest? Because I know you guys do a lot, and I love our partnership as well. But what do you suggest, especially for those who are in communities where whenever we, like for example, the programs that we provide, that they may not necessarily come to, like the conferences and the nice things and so forth. What can we do to go into the homes of individuals? What do you suggest, especially for the persons in the room that may not experience some of our vulnerable children?
Is this on? Hello? Thank you so much. I really appreciate that question, because we want to reach as many people as we can. And something that I did not mention when I was up there is our Kids Helpline service. And so that is a dual purpose service. So it offers a phone line and a text line that's available for young people Thursdays through Sundays, 3 p.m. to 9 p.m., where they can speak with a trained volunteer. It's not a crisis intervention service. Our volunteers do not give direction or counseling, but I think we really underestimate the value of a safe, non-judgmental space for young people to speak with someone and disclose what they're experiencing, what they're feeling, and what a relief that that can be when it's done in a safe space. And so that's what our Kids Helpline offers for young people. And the other side of that resource is the website and the app. And so if you go to kidshelpline.ky, we have 7 different mental health topics covered on our website for 4 different target audiences. So for kids and teens, they can go on there, learn a little bit more about different mental health topics, understand it if they feel they might be experiencing it. We offer helpful tools on how to cope and when they should really go and get help. And then for parents and educators, there's information on there as well for you where you can go and explore, how do I recognize if a young person in my life is struggling with their mental health, and how do I support them through that, and when is it really beyond the point that I have the capacity to support, and where do I go if I'm in that position? So that's a really comprehensive resource that I would encourage people to explore. And we also do community outreach. And so I know that's not technically getting into the homes, but I think being able to connect with the general public more frequently, there's power in education. I mean, I've learned so much here about the other NPOs that I'm grateful to be sitting here with. And through taking advantage of our community outreach program, requesting presentations, workshops, info sessions, I think that that is how you change one person at a time, is you really share information, and when you know better, you can do better. And when you have the tools, you can implement them. And so that's another way that I think we could really have much more of an impact in people's day-to-day life as well.